Usually when we talk about a medical diagnosis, there's this comforting expectation of precision. Like it feels like engineering, you know?
Absolutely.
You break your arm, they do an x-ray, it shows that jagged white line, and the doctor just points to the screen and says, there it is. There's your problem.
Right, it's entirely binary. I mean, the bone is either broken or it's intact.
Yeah.
And we naturally gravitate toward that kind of visibility because, well, a clear structural problem usually dictates a clear structural solution.
But the moment you step outside of, like, orthopedics and into the landscape of women's health, specifically pelvic floor health and sexual function, that X-ray machine is essentially useless.
It really is.
You can't just take a snapshot of a failing pelvic floor or, you know, a sudden loss of physical sensation and pinpoint the exact millimeter where the entire system started to break down. The diagnosis just becomes incredibly murky.
And because that diagnostic landscape is so muddy, the treatments are historically just as fraught. I mean, the medical community has struggled for decades to find solutions that address the nuance of these interconnected tissues.
Which is exactly why doctors are now turning to this radical, almost science fiction sounding alternative.
Yeah.
And that is what we're looking at for today's deep dive.
Yeah, fascinating stuff.
To figure out what's actually working in this space today, we had to dig through a mountain of data. We've got active clinical trial protocols out of the University of Iowa and MedStar Health, systematic reviews in Frontiers in Medicine and MDPI, and even official patient advisories from the British Society of Urogynecology.
That's a serious stack of sources.
Right. And our mission today is to cut through the marketing hype around a novel treatment for two incredibly common but heavily stigmatized conditions. We're talking about female stress urinary incontinence, or SUI, and female sexual dysfunction, FSD.
And the overarching theme in all of these sources is a major pivot away from synthetic structural fixes. Doctors are now literally drawing a patient's own blood, spinning it down into a highly concentrated healing serum.
Wait, injecting it back into the most intimate areas of the body.
Exactly. Injecting it back in to regenerate failing tissue from the cellular level up.
It sounds wild, honestly. Injecting concentrated blood to fix bladder leaks and orgasmic dysfunction. But before we get into the biology of how that works, we really have to look at the sheer scale of this problem.
You do, yeah.
So SUI is defined as the involuntary leakage of urine during any activity that increases abdominal pressure. We're talking about basic daily functions here: coughing, sneezing, laughing at a joke, lifting a grocery bag.
And the prevalence of this is just staggering. The data shows SUI affects up to 49% of women.
Nearly half.
Nearly half the female population will experience this at some point in their lives. You see, the pelvic floor is this complex muscular hammock supporting the bladder, the uterus, the bowels. Yeah. And when that hammock is subjected to multiparity, which is the immense physical strain of carrying and delivering multiple children, the tissues stretch and weaken.
And then you add in compounding factors, right, like obesity or a chronic cough or, you know, the severe hormonal shifts of menopause that thin out vaginal tissues.
Exactly. And that muscular hammock simply loses its elasticity and its support.
Yet, despite half the population dealing with this, nobody talks about it. It's like this hidden epidemic. And when a woman finally pushes past the stigma and goes to her doctor, the current medical toolbox is, well, it's honestly pretty grim.
It really is.
On the conservative end, patients are told to do pelvic floor exercises, Kegels. Just, you know, flex those muscles a few hundred times a day and hope the hammock tightens up.
Which often isn't enough.
Right. But when that inevitably falls short for more severe cases, the jump to the next step surgery is massive.
The surgical interventions get highly invasive very quickly. Historically, the medical field relied on mid-urethral slings, colpost suspension, and synthetic bulking agents.
Those slings sound intense.
They are. The goal of a synthetic sling is to literally install a permanent artificial hammock under the urethra to physically prop it up and keep it closed during moments of high abdominal pressure.
But putting a permanent synthetic mesh inside a dynamic, moving, highly innervated part of the body that comes with a serious cost. The BSU patient leaflet we reviewed from the British Society of Urogynecology provides some terrifying context here.
Yeah, that leaflet is a tough read.
They explicitly note a current official pause on the use of vaginal mesh tape for stress incontinence.
And the clinical trial data explains exactly why that pause was implemented. Mid-urethral sling complications occur in up to 6% of patients.
6%?
Right. And in the context of a minor temporary side effect, 6% might sound acceptable, but these complications are catastrophic.
We're talking about severe, intractable, chronic pelvic pain.
Yes. And we see mesh erosion, which is this horrific scenario where the body actually attacks the synthetic material. It causes it to harden, shrink, and literally slice through the vaginal wall or into the bladder.
Wow.
This leads to profound dyspareunia, painful sex, and often long-term disability.
And even the less invasive surgical options, like injecting synthetic bulking agents to just, plump up the area around the urethra, those carry risks too. Deep tissue abscesses, delayed hypersensitivity reactions where your immune system suddenly attacks the filler years later.
It's a huge gamble.
Putting myself in the shoes of someone dealing with a leak every time they sneeze, this is a nightmare scenario. You're choosing between doing 1,000 Kegels a day with no guarantee of relief or surgically installing a synthetic plastic mesh in your pelvis that has a 6% chance of eroding through your organs.
When the established gold standard carries a localized risk of permanent life-altering complications, the medical community is forced to search for biological alternatives. I mean, patients absolutely refuse to accept those risks anymore.
Right.
And this desperate need for a middle ground is exactly what drives the explosive interest in platelet-rich plasma, or PRP.
So instead of drugs or synthetic plastics, we're talking about harnessing the patient's own biology. And the process itself seems, deceptively simple based on the trial protocols.
It is relatively straightforward, yeah.
A clinician draws a standard sample of venous blood from the patient's arm, usually around 15 to 40 milliliters. Then they take that vial and place it into a specialized centrifuge. The sources specifically mention commercial systems like the Regen kit or the Arthrex Angel system.
Right, and those systems spin the blood at incredibly high speeds to separate the red blood cells from the plasma.
Yeah.
The physics of the centrifuge allows clinicians to isolate and extract a very specific fraction of that plasma.
That golden-colored serum.
Exactly. A serum that contains 1.6 to 6 times the normal concentration of platelets found in standard whole blood.
But, we generally think of platelets just as the cells that clot our blood when we get a paper cut.
That's the common perception, yeah.
But injecting this concentrated serum back into the body isn't about forming a blood clot. And it's not acting as a physical volume filler like a synthetic gel or a silicone implant, right?
Not at all. The real magic lies inside the platelets themselves. When platelets are activated and concentrated in this superphysiologic way, they release a massive payload of bioactive proteins and growth factors.
Like the ones mentioned across the literature, PDGF, TGF-beta, and VEGF.
Exactly.
Okay, let's translate what those acronyms actually do inside human tissue, because this is where the science feels a bit like a superpower.
It really does. When you inject this concentrated cocktail into the vaginal wall, you're essentially tricking the local tissue into believing there's been a trauma.
Like a fake out.
Yeah, it sounds a massive cellular alarm that says, we're injured, we need to rebuild immediately. The growth factor, VEGF, for instance, triggers angiogenesis.
And that's the formation of new blood vessels, right?
Exactly. It weaves a brand new network of functional capillaries to heal a wound that isn't actually there, flooding the area with fresh oxygen and nutrients.
And at the same time, the other growth factors are triggering fibroblast proliferation and collagen synthesis.
Spot on.
So instead of a surgeon inserting a foreign piece of plastic mesh to hold up the urethra, the doctor is injecting this highly concentrated construction crew of your own cellular architects.
I love that analogy. A cellular construction crew.
They send chemical blueprints to the surrounding tissue, demanding new blood flow and fresh, elastic structural support from the inside out.
And the autologous nature of this treatment is its greatest triumph. Because the serum is derived entirely from your own body, the immune system recognizes it as self.
So the risk of rejection.
The risk of a severe allergic reaction or a catastrophic foreign body rejection like we see with synthetic mesh erosion drops to virtually zero.
The biological theory is incredibly elegant, but the physics of a leaky bladder don't really care about elegant theories.
No, they don't.
We have to look at whether this biological construction crew actually stops the leaks in clinical practice. The protocols outlined in the geriatric medicine pilot study and the Frontiers meta-analysis, they typically involve injecting about 5 to 6 milliliters of this PRP directly into the periurethral area.
Right, the tissue immediately surrounding the urethra or into the interior vaginal wall. And usually this is done once a month for 3 consecutive months.
And the outcomes measured in those studies are highly promising, especially when we look at the objective data. Like, the researchers didn't just ask patients how they felt.
No, they used standardized symptom scores like the UDI-6 and the ICIQ-SF. And they employed the 1-hour pad test, literally weighing the urinary beds to measure the exact volume of leakage reduction.
And the 257 women in the Frontiers meta-analysis showed significant measurable improvements, but the data reveals a fascinating nuance here.
It does.
The patients with mild stress incontinence responded beautifully to the PRP injections, but the patients with moderate to severe anatomically shifted SUI saw far less benefit.
And the urodynamic testing from that meta-analysis provides the mechanical explanation for this discrepancy. To understand the physics of urinary continence, researchers measure two distinct variables.
Okay, break these down for us.
We have ALPP, which stands for abdominal leak point pressure, and FPL, which is the functional profile length.
Let's look at this through the lens of household plumbing to make the urodynamics clear. ALPP is the amount of physical pressure your bladder can withstand before urine forces its way out.
Yes, it is the strength of the seal.
And the FPL, the functional profile length, is the actual physical length of the muscular tube, the urethra, that maintains that pressure. It's the length of the pipe itself.
The clinical studies demonstrated a massive, statistically significant increase in the ALPP after PRP treatments.
Meaning the seal got stronger.
Exactly. The bladder could suddenly hold back vastly more pressure during a cough or a sneeze, but the measurements showed absolutely zero significant change in the FPL.
So the length of the structural pipe didn't change by a single millimeter.
Not at all.
So the PRP is acting like a restorative treatment for the rubber washer inside a leaky faucet. It improves the health, elasticity, and blood flow of the surrounding tissue, which dramatically tightens the functional seal, the ALPP.
That's right.
But it doesn't do gross carpentry. It can't lengthen a pike that has physically dropped or shortened due to severe pelvic organ prolapse.
And this functional restoration explains the clinical split perfectly. For a woman with mild SUI, where the anatomical structure is mostly intact, but the tissue has just lost its tone and elasticity, rejuvenating that seal with PRP works wonders.
Right.
But for a woman with severe structural prolapse, where the urethra has physically shifted out of place, a tighter seal just isn't enough to overcome the gross anatomical failure.
Now, if injecting these potent growth factors into the anterior vaginal wall rebuilds the urethral seal and triggers vast networks of new blood vessels, it raises an obvious anatomical question.
It definitely does.
The urethra and the anterior vaginal wall sit mere millimeters away from the clitoral network and the highly innervated sexual structures of the pelvis.
The anatomical proximity is undeniable, and the medical field quickly recognized the dual potential here. The same vascular and structural decay that causes incontinence often contributes heavily to female sexual dysfunction, or FSD.
Which brings us to the commercial side of PRP, which is heavily marketed by clinics as the O shot, or orgasm shot.
Right, and the clinical protocol shifts slightly here. Based on the data, doctors inject a smaller volume, usually about 2 milliliters of PRP, into the distal anterior vaginal wall and directly into the clitoral structures.
Following that same schedule of once a month for 3 months.
Yes. But before we look at the clinical outcomes for FSD, it is vital to distinguish the regenerative O-shot from other commercial treatments that sound similar but operate on entirely different principles.
Oh, this is so important. The sources from Nor Women's Health highlight the frequent confusion between the O-shot and the G-shot. They sound identical in marketing materials, but they are functionally opposite.
Completely different. The G-shot uses synthetic hyaluronic acid,
which are the exact same dermal fillers like Restylane or Juvederm that plastic surgeons inject into lips or cheeks.
Exactly. A doctor injects that synthetic gel directly into the G-spot simply to physically plump it up, creating a larger surface area to enhance friction during sex.
So the G-shot is just a temporary physical augmentation.
It operates like a speed bump. It does absolutely nothing to address the underlying cellular health, nerve damage, or vascular decay that actually causes sexual dysfunction.
And because the body naturally metabolizes hyaluronic acid, that physical speed bump just flattens out after about 3 to 4 months.
Right. The O-shot, relying on the patient's own concentrated platelets, functions entirely differently. The goal is not temporary volume. The goal is long-term tissue regeneration.
Because it relies on the body's natural biological healing cascade.
Yeah, so it takes up to 3 months for the angiogenesis and cellular turnover to hit its peak effect, but the regenerative results can last anywhere from 14 to 18 months.
And the MDPI systematic review tracked these regenerative outcomes using standardized metrics like the Female Sexual Function Index, the FSFI, and the Vaginal Health Index.
And the data showed marked, sustained improvements across the board. in arousal, natural lubrication, and overall sexual satisfaction.
But the specific neurotrophic effects detailed in the renal study take this a step further, and the side effects recorded in that trial were profound.
They really were.
2 of the patients in the renals trial reported experiencing extreme sexual arousal. The clinical notes specifically detail episodes of spontaneous orgasms and ejaculatory orgasms simply from having their own concentrated blood injected into the tissue.
Those extreme responses highlight a crucial component of PRP that goes beyond just building new blood vessels. Platelet-rich plasma contains nerve growth factors that actively encourage neurogenesis.
Which is the repair and regeneration of damaged peripheral nerves.
Exactly. When you supercharge the vascular supply and simultaneously regenerate the nerve endings in a highly innervated area like the clitoris, the physiological awakening of that tissue can be incredibly dramatic for patients who have suffered from decreased sensation.
So we have a treatment that uses a patient's own biology to rebuild the urethral seal, stop daily leaks, and regenerate sexual nerve function to the point of spontaneous arousal. I mean, it paints a picture of a biological miracle.
It does sound like one.
But we promise to cut through the marketing hype and ground this deeply in clinical reality. To really understand the value of PRP, we have to look at what happens when it steps into the ring against the surgical heavyweights.
And the Dinesh Biju trial provides the ultimate reality check here. This was a pivotal, head-to-head randomized controlled trial conducted in Iran.
Okay, tell us about the setup.
The researchers took a cohort of patients suffering from stress urinary incontinence and divided them. One group received the autologous PRP injections, and the other group underwent the traditional midurethral sling surgery.
And when you look at the raw efficacy data from that trial, the surgical sling absolutely dominated the PRP injections.
It wasn't even close.
They measured success using symptom severity scores, where a lower number indicates a complete resolution of symptoms. After 3 months, the group that underwent the invasive sling surgery saw their symptom scores plummet to a near-perfect 2.2.
Right. While the group that received the biological PRP injections only saw their scores drop to an 8.0.
In terms of sheer mechanical ability to stop a leak across a broad population, the surgery is mathematically vastly superior. It's the gold standard for a reason.
It is.
So let me push back on the entire premise of this regenerative approach then. If the synthetic sling surgery is that much more effective at actually stopping the problem, why are patients and doctors spending so much time and money on blood injections?
That's a fair question.
Shouldn't the medical consensus be to just perform the surgery and give the patient that 2.2 symptom score?
If we existed in a theoretical vacuum where only efficacy mattered, then yes, the surgery would be the only option. But medicine is never practiced in a vacuum. Every single treatment is a delicate, deeply personal calculation of risk versus reward.
The Dinesh Biju trial perfectly encapsulates that core dilemma, doesn't it?
It really does. It all comes down to individual risk tolerance.
Let's re-examine that risk tolerance by looking back at the BSUG leaflet. The mid-urethral sling will likely cure the incontinence, giving you that perfect 2.2 score. But to get that cure, you have to accept a 6% risk of catastrophic permanent destruction of your pelvic floor.
Exactly.
If you fall into that 6% and the mesh erodes, you're looking at a lifetime of debilitating nerve pain and the inability to ever have painless intercourse again. It's like a statistical game of Russian roulette with your quality of life.
And that is where the value of PRP becomes undeniable.
Yeah.
It is measurably less effective than surgery. An 8.0 on the symptom scale means the patient might still experience occasional mild leakage. But the side effect profile of PRP alters the risk calculus completely. Across all the clinical trials and systematic reviews we analyzed, the adverse events associated with PRP were incredibly mild.
The worst side effects documented were temporary vaginal spotting, transient straining to urinate, and in one specific study, mild hematuria, which is blood in the urine and dysuria, in about 28% of patients.
Crucially, though, every single one of those adverse events resolved completely on their own within a few days. They required zero major medical intervention.
Wow.
There were no foreign bodies hardening inside the tissue. There's no permanent nerve damage. There was no irreversible surgical scarring.
So PRP isn't replacing surgery for the most severe cases, but it acts as a vital bridge. It provides a biological, low-risk, regenerating option for the millions of women who want more profound relief than daily Kegel exercises can offer, but who absolutely refuse to gamble their future on the 6% catastrophic failure rate of a synthetic mesh.
It represents a fundamental shift in medical philosophy. It's treating the female pelvis as a living ecosystem that requires cellular nourishment, and vascular restoration, rather than treating it like a broken machine that just needs a synthetic plastic part bolted into place.
We've covered an immense amount of ground today. We explored the staggering hidden prevalence of female stress, urinary incontinence, and sexual dysfunction, conditions that dictate the daily lives of nearly half the female population, yet remain shrouded in stigma.
Yeah.
We analyzed the terrifying reality of synthetic surgical mesh and why the medical community is actively pausing its use.
And we detailed the precise cellular mechanisms of platelet-rich plasma. We looked at how a centrifuge isolates growth factors like VEGF and PDGF to trick the body into an aggressive healing response.
We saw how this autologous serum builds new blood vessels, regenerates nerve endings, and tightens the functional urethral seal without permanently altering the structural anatomy.
Understanding the profound difference between a temporary synthetic fix like the G-shot or a mesh sling versus a regenerative autologous treatment like the O-shot or perurethral PRP is all about patient empowerment.
The medical landscape for women's health is shifting rapidly. Having this depth of knowledge gives you the vocabulary to advocate for yourself. It empowers you to sit down with your doctor and have a highly nuanced conversation about your unique anatomy, your specific quality of life goals, and ultimately your own personal threshold for risk.
The most exciting aspect of all the clinical data we reviewed is the realization that the body retains the blueprints for its own repair. It sometimes just requires the right concentration of its own resources to execute them.
We started this conversation talking about x-rays and broken bones, the comforting binary idea of a clean, visible structural fix. But human biology is not a static structure. It's an ongoing, living process of decay and renewal. We are just now beginning to harness the concentrated power of our own platelets to regenerate the pelvic floor and actually reverse localized tissue aging in the most complex, intimate parts of the human body.
It completely redefines the boundaries of modern healing.
It really does. So I want to leave you with a final provocative thought to mull over as we sign off. If a simple vial of our own blood already contains the exact cellular blueprints, the stem cell signals, and the nerve growth factors required to rebuild failing valves and restore profound physical sensation, well, what other irreversible aging processes in the human body are just waiting for the exact right concentration of our own biology to heal them? Until next time, keep diving deep.